Good morning, Chairman Woolsey, Ranking Member Ms. McMorris, Rogers, and subcommittee members. I'm a medical doctor specializing and board certified in occupational medicine. I treat employees for injuries and illness incurred in the workplace. For 24 years, I've examined workers under 2 different state workers' compensation systems, as well as federal employees under the Federal Employees Compensation Act and the Longshore and Harbor Workers Act. I make decisions every day about impairment and disability. These are 2 different terms. Impairment refers to loss of function. It simply means, for example, that the grip is weak or that the arm has less mobility, for example. Disability is the effect of that impairment on the ability to perform a specific job. For example, I injured my right shoulder years ago. My arm was so weak I could hardly lift a gallon of milk. I couldn't reach higher than my shoulder. I was impaired. Let's say 5%. I could do all my work as a doctor, so I was not disabled. I was 0% disabled. On the other hand, if I were a carpenter with the same 5% impairment, I'd likely be 100% disabled. Doctors' impairment ratings are an estimate of how much loss of function is present. Disability is how that function loss affects a person's job. I have significant experience with the editions of the guides. I've taught doctors about impairment ratings and explained ratings to patients. I can state that the 6th edition is dramatically different from prior editions, and as the authors say, a paradigm shift. It's controversial for good reason. It does not appear to be evidence-based. In fact, comments in the 6th edition reiterate that it is a consensus document, and also mentioned, when they do talk about evidence-based research, that it is not adequate at this point for doing impairment ratings. It produces impairment ratings far different from those in prior editions, most of them lower, and without adequate support for doing so. In addition, it's difficult to use, requires extensive training of doctors, and is inefficient. There are many unexplained rating changes in this new edition compared to the earlier editions. Of 35 cases that I reviewed, 21 were lower in the 6th edition. Several were a lot lower. In another series, I saw that there were 52 cases, 46 were rated lower in the 6th edition. In that same report, a series of 200 cases also showed large number of reduced ratings by the 6th edition. One of the guide's authors presented a small series, also with lower editions by the 6th edition, and actually, had he done the math correctly, it would have been lower than he showed in this example. The impairment rating for total knee replacement with good result is 37% of the lower extremity in the 5th edition and 25% in the 6th. I didn't find any objective reason for making that change. The 6th edition is needlessly complex. For 6th edition ratings, I charge more because I find its methodology clumsy and difficult to work with. Every rating under the 6th edition takes several steps, regardless of how straightforward the rating could be. After the examination, plus a required patient questionnaire, the doctor first goes to the chart for the diagnosis, then he goes to 3 other charts for examination results, test results, and claimant's function. The doctor gets numbers from these 3 and subtracts each number from the number assigned to the diagnosis, then adds these 3 sums together. That sum is subtracted or added to the number at the diagnosis chart to find out where, in a very narrow range, the final rating really is. That's hard. 5th edition rating requires a physical examination and sometimes tests. The doctor goes to a table for each pertinent measurement and matches the claimant's measurement with an impairment percent from the table. For some ratings, there's more than one table, but even then, in most cases, it's not that difficult. With some guidance, cases could be rated by an attending doctor. I've even given phone instructions to doctors, enabling them to do accurate ratings. It's difficult to get those treating doctors to embrace the impairment rating and the guides. Most step back slowly if I bring out the book, but I believe they will run from the complicated multi-step arithmetic and rules of the 6th edition. Doctors have become familiar with the 5th edition over these 10 years, and the system has some stability now. Adding the 6th edition, an untested and unproven departure from the format of 40 years, doesn't seem worth the disorientation it will cause. 6th edition ratings take more time. Experts doing identical sample cases averaged 5 minutes to rate a case by the 5th edition. To do 6th edition ratings, these same experts in same cases averaged 25 minutes per case. In addition, early reviews of the 6th edition ratings show an error rate that's similar to those of the 5th edition, so this new edition doesn't seem to fix the problem of training. The 6th edition authors suggest that there is a better inter-rater reliability, but that is likely due to the narrower range of ratings allowed. The 6th edition fails to grasp the essential factor of impairment assessment, functional losses in activities of daily living. Instead of being the focus for the rating, they are relegated to the last position of 3 modifying factors, and in some cases actually can be thrown out. The validity of impairment ratings will not improve until direct measurement of functional loss in activities of daily living becomes the standard. Reduced rating values are not evidence-based, nor is there any explanation given. The 5th edition, for all its shortcomings, more accurately allows assessments of functional losses than the 6th edition, in my opinion. Thank you.